serve system-wide with digestive health providers like Dr. Flora here in managing programs and best practices and pathway development around digestive health instances. So I'm going to give that to you.
So I'm Ken Flora, and I work with Kent in the liver clinic at the Oregon Clinic, and we're coming at you with a big system perspective. Oregon Clinic has 60 gastroenterologists. We're affiliated with Providence Systems, which at present is the third largest health provider in the country. It covers the 7 western states. We're going to talk about things that involve primarily Oregon and Washington. But as you might imagine, a big system has a certain amount of inertia. But once the elephant gets up, we're relatively nimble and we're allowed to try multiple things in different places at the same time. So we're going to give you a little taste of some of the projects we're doing at present. We have some sort of outcome information. We will be getting some outcome information. And then we have ideas for all sorts of other things based upon discussions like this, what we're hearing that you need. So first slide. This is our recurrent message. The big take-home for a provider like myself is that most people with hepatitis C do not know that they have hepatitis C. And not only is that an education thing amongst patients, it's an education thing amongst a big system. Big system administrators, big system providers. As you just heard in a place like Medford, there's all sorts of misinformation. It is not limited to communities, it's limited to the big systems. So as you've heard this morning in Oregon, we believe there's 90,000 hepatitis C patients. 3/4 of those people are unaware that they're infected. They're moving up through the stages of SCAR. By the time practitioners like Kent and I meet them, the likelihood that they're now cirrhotic is nearly 50%. We were both born with white hair, so you'll have to trust me, we've done this long enough that we have watched our practice change from simply managing hepatitis C to we spend the majority of our time managing end-stage liver disease and cancer. When I went through training, liver cancer was a once or twice in a career disorder. Now in our cancer conferences, we're presenting 5 to 8 new patients a week. So all these numbers you're hearing in real life are true. This is moving toward people presenting at more advanced stages. Fortunately, we believe a lot of it is reversible if we can treat them. Next slide. Now, in order to identify patients, as you all remember, it meant that someone would have to stand up, admit to certain risk factors, and then ask for screening. Huge stigma, small results. So instead, the CDC has flipped it. Now all we have to do is admit that we're old and we'll all get tested for hepatitis C. What it means is we'll be testing lots and lots of patients for relatively few positives. But as we'll get into in a minute, that was part of our problem. Big systems like Providence were under the impression that everyone tested was going to be positive for hepatitis C, so that we would test within their system hundreds of thousands of individuals, and that they would be faced with a huge onslaught of hepatitis C patients that would bankrupt the system and doors kind of shut because of these fears that are gradually getting dispelled by all the things that you're doing.
Next slide, please. So in an effort to screen these folks, there is actually some pre-work to this launch for the system in December 2016. We know by experience at one of our sites in Providence that they saw in 18 months when they released actually it was a passive BPA, they saw a over 28% increase in screening. So we thought, wow, that's a great experience. How can we implement that across the system? So like I mentioned, in December 2016, we launched, it wasn't passive, it pushes out to the physicians a best practice alert request that says, hey, your patient is in this cohort, they need to get tested. And so this work, we, again, as I mentioned, as a system, we have these virtual institutes. We have these focus groups that focus around disease states, and this one is titled the End-Stage Liver Disease Viral Hepatitis C Group. Said we want to support this, we want to get it out there. And so alongside this BPA, we knew we couldn't just say, hey, go screen. We needed to provide them the tools both at the physician level and at the patient level to be able to manage through the process once they've sent a patient for screening or identified a positive case. So that's just a look at that best practice alert. Again, it comes up through the system as a patient comes into a primary care or even a specialist office with the intent that somebody's going to get this person screened in the system if they're in that cohort. Next slide, please. So again, as Dr. Flora mentioned, we are actually now in 7 states. This is data representing 5 of the states that we launched this best practice in. Again, we launched it December a year ago. As a system total, we're seeing a 19% increase on our screening rates. So we're seeing aggressive, some places a little bit more, some places a little bit less, but we're seeing aggressive treatment plans or aggressive screening and plans to move into linkage to care. Because as Dr. Flora mentioned, we got to be nimble. We've got to get these patients not only identified, but how do we care for them through that process?
Providence has been able to do this by utilizing a common electronic medical record, which not everyone has available. In the city of Portland, virtually everyone uses Epic. So this is a best practice advisory that pops up on the desktop of a primary care provider who's utilizing Providence Epic, but it could be adapted through all the different forms of of Epic as well. The other sort of side effect of that age cohort is that many different diseases present within the baby boomer population, many of which are currently being screened for. So Providence has allowed us to capture people as they prevent for other modalities of screening. We're looking at screening Hep C in patients who present with women that present for mammograms. Swedish in Seattle is doing Hep C screening on patients who present for screening colonoscopy. So this cohort has made it easier for a system like this to kind of overlap and do simultaneous screening. Next slide. This is data that looked at what happens when you screen huge cohorts, and this has sort of allayed the fears of big systems like Providence. So given the natural history and the screening characteristics of what we're doing, out of every 1,000 adult patients that are potentially at risk for hepatitis C, a third of them are baby boomers. 10 of those will have a positive antibody. Only 7 of those will have RNA positive, which results in 7 patients per every 1,000 that are tested actually having hepatitis C. So some of the heat and, oh God, they're coming, was taken off by numbers like this. Next slide.
So we know not every, as Dr. Flora mentioned, that not everybody who goes into the screening is tested positive, but we do want to ensure that folks who get tested positive get access to care. We're in large communities like Portland and Seattle. We're in smaller communities as well, like Spokane, where I'm from. And we don't have hepatology resources in every corner of our system. So we really set out to create opportunities for linkage to care. And I know that you've heard about Project Echo, and I'm so excited to hear about it's happening here in Oregon. We're looking at how we can expand that as well in regions like New Mexico. I know that there is a New Mexico program, but in West Texas, we've got that reach now. So we need to make sure we provide our primary care providers the opportunity to help assist and be a care provider within the care plan of folks with hepatitis C. In addition, we've launched as a system 4 current pharmacotherapy programs. They are within these regions, so Torrance, California, Portland, Seattle, and Spokane. And really the intent is we've aligned with pharmacists to be able to co-manage folks who are positive for hepatitis through their disease state. Every program's a little bit different. It depended on the resources that were available in those regions, but they've been very successful in caring for our patients, making sure that they get not only the hepatitis C drug and get to that, SVR12 load, but they also get those wraparound services that come along with needing to support their care.
Next slide.
We can pass over.
Next slide. So in Portland, the big push is wrapping around a model called 340B, which I'll explain in a moment. We acknowledge that hepatitis C treatment has become quite simple and relatively side effect free, and we think that in order to get all 90,000 of Oregonians with Hep C treated, we're going to have to involve primary care or other, say, nurse practitioner or pharmacy clinics. To back up a little bit, a 340B clinic is a federal program where hospitals and designated clinics that provide a high level of indigent care at a loss are allowed to see patients, charge half price for their medication, buy medications for them at half price, like interferon or direct antivirals, but yet then turn around and bill the payers full price. These institutes are then allowed to keep the difference in cost to kind of allay all those expenses they've incurred by doing indigent care. We thought that we would be able to set up 340B clinics. Spokane has one. We have simultaneously launched 2 in Portland, one at Prov Portland and one at St. Vincent's. The problem we've run up against is that though the idea was buy drugs at cheaper cost, charge payers full cost, most of the payers that we see that are involved in hepatitis C are CCOs. CCOs have the ability to independently negotiate cost for drugs, and so a lot of them have undercut that 50% rate that the 340B clinic was going to purchase drugs, and nobody wanted to be billed full price. So the concept has changed to pharmacotherapy clinics. They are modeled after anticoagulation clinics, where a provider will diagnose someone with a DVT or atrial fibrillation. They will go to the clinic, and pharmacists, PharmDs, will then manage the anticoagulation, the labs, and the side effects. So this is kind of a combined effort to include primary care providers, and then moving down the algorithm, triage patients into higher levels of fibrosis, lower levels of fibrosis. Lower level patients will go directly to the pharmacotherapy clinic, where the pharmacist will have license to decide what medications, and then to carry on from there. Once patients' therapy is completed, they'll just go right back to the PCP and never have to see a gastroenterologist, infectious disease person, or hepatologist. On the other hand, even once advanced fibrosis patient is cured, there will still be issues for which they will need to be surveyed, like hepatoma, esophageal varices, and so on. They may have even presented with complications related to their liver disease. So for that reason, individuals with higher degrees of scar will go through GI, hepatology, or in the case of co-infected individuals, ID. Those clinics will decide what medication, because everyone's a little different for every circumstance. The patient will go to the clinic and then go back to the GI, ID, hepatology clinic. So this is a very quick look. This has taken a long time to kind of get the system up and running and give us its backing, and we anticipate that they're going to allow us to try many other things. Fortunately, there's momentum now that they've started, and we hope to be nimble and be able to provide you more results over time. Thank you very much.
Thank you.